Hello, everybody. Welcome to another episode of Conversations in Health and Care Improvement. Today, with a topic that is top of mind for many people, with a sense of excitement and possibility, and also a sense of I need to know more. So, we're really excited to have guests like Raj and Josh, who Amar will introduce more in detail, but I am Pedro Delgado, Vice President at the Institute for Healthcare Improvement, and I'm joined today by my colleague and friend, Amar Shah. Amar.
Thanks, Pedro. So much fun recording these with you. I'm learning a ton from these conversations, and I hope all our listeners are too. I'm Amar, National Clinical Director for Improvement for the NHS in England and Chief Quality Officer at a healthcare system called East London NHS Foundation Trust. Thrilled to have Josh Clark and Raj Ratwani with us today to dive into the topic of data and analytics. We're obviously theming this whole series around health and care improvement. And I guess for many people, when you think about data and analytics, you will straight away be thinking about data over time, variation, run charts. Josh and Raj are both going to help us think about slightly more advanced uses of data and analytics that we could potentially be learning from around the world. So thanks a million for joining us both. Let me invite each of you perhaps to say a little bit about yourselves and your background and your experience in the field, and then we can take it from there. Josh, do you want to kick us off?
Yeah, thanks, Amar. It's great to be here with two of my favorite people in the healthcare quality space, and Pedro and Amar. So thanks for having us. Um, I'm Josh Clark. I currently newly work for IHI as a Vice President of Quality Safety Operating Systems, but came to IHI to do better integration and better optimization of technology to essentially help us design better systems and get better outcomes. But the analytics component of that is huge, and I've had a lot of experience with that. My previous role was overseeing Jefferson Health's quality and safety program called On Point, in which we started to really test this theory of a clinical operating system and the application of it really globally. So pleased to be here and looking forward to the discussion.
Thanks for joining us, Josh, and welcome, Raj. Lovely to have you with us.
Thanks, Pedro, Amar. Thanks for having me, and really great to meet you. It's the first time I'm meeting both of you, and I've kind of known Josh for a few years, I guess. So I'm Raj Ratwani. I'm with Minster Health. Minster Health is a 10-hospital, about 400 outpatient clinic healthcare system in the Mid-Atlantic region of the United States. So we cover Washington, D.C. into Maryland. And I have two roles inside of Minster Health. I serve as the Vice President of Scientific Affairs for our Minster Health Research Institute. So this is essentially the research infrastructure for our healthcare system in partnership with Georgetown University School of Medicine. And then I also serve as the director of what we call the National Center for Human Factors in Healthcare. And that team is this incredible team of about 30 people that are really focused on applying the science of human factors to improve quality, safety, and efficiency. And as part of that, we have been deep into data science, data analytics, and now artificial intelligence, and really focused on how do we make those kinds of techniques, capabilities, and methods applicable to all to really improve safety. So looking forward to jumping into the conversation.
Thank you both. And what we will try to do is to do a quick look back, focus on the present, and also explore a little bit of the future. But knowing what you know about human factors, about safety science, about reliability, about continuous learning and improving systems of care, we have evolved our efforts over the last 2 decades, particularly since Tour is Human and Crossing the Quality Chasm. And we are in front of a set of possibilities that seem very exciting. But can you talk a little bit about what you have seen over the last number of years in the evolution of the use of technology to learn better, faster, to make care better, to make workflows better, and so on. And then we'll get to the present moment. But can you talk a little bit about the evolution of that and how it's perhaps different and how it's perhaps similar to what it used to be? Raj, maybe we'll start with you.
I think it's been really interesting to see how much technology has really come into healthcare in the last 10 to 15 years. And I would actually characterize it as sort of it's a bit of a mixed bag. There's been some tremendous benefits to the technology that's come in, and it's served to advance patient safety and improve our ability to deliver care. And then it's also posed lots of challenges in certain ways. And I'll bring up as a kind of classic example of this, I'll point to the electronic health record as probably the biggest technology disruptor up until AI that we've probably had. And I think our experiences in the UK and in the US have been different in some ways and similar in some ways. And so I'll speak to the US experience. In 2009 was this big federal push for healthcare facilities across the United States to adopt electronic health records. And so usage went from 10, 15% now up to something like 99% of healthcare facilities in the United States use an electronic health record of some kind. And when you think about that, that's a very dramatic change, number one. Number two, the opportunity there is incredible because we've now just digitized all of this information that from a quality improvement, patient safety perspective, we should be able to leverage in ways that we just couldn't do when things were on paper. And so that's been a huge opportunity for us. And then, of course, there have been some challenges there, right? Some of those challenges have been, well, the introduction of this new digital platform has faced a lot of usability issues that have actually increased the number of patient safety issues or introduced new types of patient safety issues. And some of the data that are being collected inside of those electronic health records that we actually want to leverage for improvement purposes aren't actually as quality and as sort of fine-grained as we want. And so we thought we might be able to do a lot with that information, and it's actually a little bit more difficult. And so when I say it's sort of been a mixed bag, I think there's been some clear benefits to this. There's also been some real challenges. Probably most importantly, and then I'll pass it over to Josh, is that what we have done is we've learned a lot in this technology transition. And as we look to what I like to characterize as the next big disruptor, which I think is artificial intelligence coming into healthcare, we have to leverage what we've learned. We absolutely have to leverage what we've learned from electronic health records to make that transition even smoother, hopefully.
It's a great setup, Raj, and one of the things that you all do so well is studying the impact of EHRs, how they can be better leveraged. And if folks haven't checked out Raj's research on that, it's really world-leading stuff. I would say, in addition to that, we went from a place where we were struggling to have meaningful, actionable data that was valid and useful to drive improvement. And it was this constant struggle to this place to where now we almost have too much data. And if we're not organizing that and prioritizing it and being very selective and intentional about what we show frontline clinicians and ask them to improve on, it actually can be a source of frustration because the staff are already working, as Raj said, in unoptimized technology. And now we've gone from a place to where they didn't have any data to understand performance. Now there's so much data and there's a lack of prioritization that we have to be better about making sure that there's an understanding of what priorities are and showing staff data that they can actually influence, that they can understand, and that they can impact in their daily work.
Tell us a little bit, Josh, Raj, about some organizational journeys that you've either been part of or you've seen that have started to take this wealth of data and information that now exists in digital systems and start to bring it to clinical teams in a way that helps them manage daily work and also help them figure out where's the really wicked complex issues that will benefit from an improvement effort. Because from what I've seen, Josh, let's start with you from the work you did at Jefferson Health. I mean, from the little I've seen, you found a way to bring it to your clinicians and integrate it into the way in which teams come together and think about their practice.
Yeah, I mean, just some context on Jefferson Health. When I joined, there had essentially been 5 mergers in less than 6 years there. And so there was a lot of disparate systems. There was a lot of data, but there was not a lot of access to meaningful, validated data. And so when we launched the On Point program there, we also launched what we called On-Point Insights. And that was just leveraging a business intelligence platform. It's really nothing special, but there was a commitment to the staff that there was going to be one source of truth, and that it would be one click away from them at all times. So whether on their phone, on the computer, in the EHR, they were one click from our priorities. And then the other commitment to them was that if we were going to show you data in your workflow, it was going to be actionable and meaningful to you. And so for so long, clinicians have been shown outcomes in ways that they don't even understand. When I was first asked to lead a PI committee as a nurse in an ICU, they handed me a bunch of SIRS from 6 months ago and had no idea what the impact of that was and how to make it better and even how to interpret it. And so by communicating to the staff this commitment that we're going to give you data that you can actually influence in your shift and that's meaningful to your work and to your patients, and you're always going to know what our priorities are because it's going to be one click away. And that when you're looking at data on Point Insights, for us, it is the most up to date, and it's valid, and it's been pressure tested to make sure that it's correct. And so part of that is just a strategy to manage all this different data coming from all these different systems. I still talk to a lot of health systems today that have a business intelligence platform and they have a data warehouse, but they're not feeding in key data from the systems to understand true performance in either a daily basis or a large scale. So I think we have a lot of work to do there. We have the technology that we need. We have the data that we need. But how we integrate and make that interoperable and be intentional about what we show the staff, I think we have room to improve on.
Yeah, it's no small effort, is it? I know from my own work in East London where data and analytics fell into my portfolio about 6 or 7 years ago. We've had to really completely rip up the back end and create an entirely new integrated warehouse in the cloud, feeding in all sorts of data from different systems, not just from the EHR, and we have 5 EHRs, but from human resources, from safety data, from patient feedback data,
Yep.
finance data. It's a complicated thing, and then to make it all match at the unit level is another whole effort indeed. So there's a lot of technical back end work required in order to then be able to bring something meaningful to a clinical team, and something that perhaps not everybody really appreciates how much architecture and engineering is required at the back end. Raj, I wonder whether you could share a little bit of your insights from MedStar Health about how you've started to make data available in this sort of way.
Yeah, well, first, I completely agree with what you just described, Amar, and also what Josh has said. The concept of having a single source of truth is so important because oftentimes what happens is we're pulling these data from different systems because of this interoperability challenge, and nobody can agree on any particular number, whether it's something from how many physicians do we employ to how many patients did we see yesterday in the emergency department. It's just nuts when you think about that, especially when you compare it to other industries, high-risk industries, that have really figured this out. So I think that this focus on kind of the back-end processing and making sure we have a single source of truth is critically important. In addition to that, a lot of our focus has been on how do we bring some of these very easy-to-use tools to our frontline clinicians, to our patient safety officers, and really reduce the friction of kind of all that data wrangling. And importantly, what we want to do in certain contexts, and this is where we focused a lot of our attention, specifically around something like incident reporting. And so most healthcare facilities collect patient safety event reports or incident reports. We all call them something different. And there's clearly value in those data, but we have to enable our patient safety officers, analysts, and others to be able to actually explore those data and identify trends and signals in those data. And historically, that process has been incredibly difficult, right? We give them very broken tools to use, and they spend hours and hours and hours fishing around to find something of value. So where our focus has been is to say, well, let's fix the back-end processes of this. Let's get to a single source of data. Let's clean those data up. And importantly, let's provide those patient safety analysts, officers, and others, the frontline users essentially, with a super hyper user-friendly tool. And let's enable them to, as Josh said, see things in one click. And also, let's follow great design principles to make it so that if they have a hypothesis or hunch, they can track that down very easily. And specifically, it's things like dashboards that are real time dynamic and can filter on demand, all those kinds of things where historically we would say, okay, we have to submit a query to pull a set of data down. Oh, now I want to understand how many falls happened on this unit. Let me submit a new query, pull those data down. If we can change that to say single click, I can filter the data and I can see it right away. Oh, I want to explore how many of those falls involved patients over the age of 65. Fantastic. Single click and I can explore those data. So we absolutely want to be able to give people answers and enable them to see the information right away. And we want to enable them to be able to explore when they have hypotheses and hunches so that they can really make progress.
You're both highlighting the necessity and the importance of partnership. So it's not just the technology, but it's the human element of it. And in our conversations recently, Josh, you've talked about a socio-technical system. Can you talk briefly about this concept of care operating systems and frame it for people? I recently read the HBR piece on improving and fixing systems, not people. But can you reflect on the socio-technical systems, on the care operating system concept, and on how that has a potential to impact the here and now? You guys have walked the trajectory of the key things that have changed, the key opportunities and challenges, and then through Amar's question, kind of enter the space of decomplexifying in a way this very complicated set of tools that we have at hand by ensuring that the human element continues to be core. Can you elaborate on the socio-technical system, care operating systems, and how you see opportunities in the here and now? And Raj, we'd love you to reflect on that, because I know from what I know about your work that you are very active in the space of building a solid care operating system.
Yeah, thanks, Pedro. So I have to go back and give credit to colleagues that ended up working with me at Carilion Clinic in Virginia in partnership with Virginia Tech, and one of Raj's great colleagues, Dr. Sarah Parker, who really started to help us see healthcare delivery differently through the lens of human factors engineering and systems engineering, and that we had been trying to take on these really complex systems and drive improvement using QI and improvement science and lean. But we weren't doing enough to understand how the system was performing and how changing something in the system affects other outputs. And so conceptually, that's where this clinical operating system concept was born, and started to be tested through the integration of folks like human factors PhDs and systems engineering PhDs who were actually working in the day-to-day clinical operations with us, and helping us prioritize true system improvement opportunities. And so the care operating system work that we're doing at IHI is starting to help create that movement, because Raj is part of the Human Factors and Ergonomics Society. There's a great group called Transforming Healthcare with Human Factors, led by a colleague of mine, Dr. Lori Wolf, that I worked with. The people with the skills are out there that can actually help do this work. But the problem is that the industry and the providers and health systems don't realize that they need them. So, just understanding the basics of a socio-technical system, which I see a lot in the NHS literature, which is great. It's not that common that folks are using that term and even understand what it means. But essentially, we have been very focused over the last 20 to 30 years on the socio aspect of the socio-technical system. So we've been trying to teach our way to safe and culture our way to safe and do all of these things to improve human performance. We've been asking our clinicians to be more resilient and to adapt to the system that's not optimized to produce the results that we want. So essentially, we are trying to flip the script on that. The goal of the daily operations of a health system should be to be continuously evaluating how the system is performing, and then doing appropriate analysis and evaluation and triage to make sure that you're improving the system to make it easier on the frontline clinicians. And that starts to actually create the culture that you want, because they see that you're actually investing in improving their daily work, and they'll start giving you more feedback about how the system can be improved. And so, this concept about where data fits in is really important, because clinicians want to have better care for their patients, and they need the insights to be able to make the right decisions at the right time. And if they see that you're doing that in a way where you're just not asking them to do more and be better, it creates a positive snowball effect for the organization.
Raj, any reactions or comments on what Josh just described?
I'm not sure how familiar listeners are with the concept of a socio-technical system, so it may be worth it for us to just spend a minute sort of defining that. And Josh, I'd look to you for kind of help in this. I can start by giving my definition of it, which is definitely more from the systems engineering perspective. So when we say socio-technical systems, we're talking about thinking about a system as different component parts that include technical components and social components, things like people, process, technology, medical devices, you name it. And the system part of this is those components all interact to give rise to behaviors that are different and sometimes more than simply the sum of those parts. And so we have to think about those interactions between all those different component parts. Let me pause there. Josh, does that definition kind of resonate with you? What would you add or change there?
No, absolutely. You're the right person to give the definition on that, Raj.
And I just wanted to bring that up because I think people that may be listening may not be familiar with the concept of a socio-technical system. I think what Josh said is spot on, and give so much credit to Josh, his team, and others like him that have done the hard work of actually operationalizing a socio-technical system. Historically, what's happened is there have been a lot of human factors people like myself, and Josh mentioned Dr. Sarah Parker, who's just amazing. And we've always talked about this at a pretty theoretical level. Like, we've explained these concepts, and we've been beating on the drum saying, hey, healthcare facility systems, etc., need to adopt this. It's one thing to do that. It's something completely different and much more impactful, I think, to do what Josh and his teams do, which is actually take these concepts and now implement them into a clinical environment to show differences. And we should just, one, recognize how challenging this whole thing is. If you just break down the description that we gave around socio-technical and systems. So first, historically in medicine, anything socio is ignored. Right? We like to focus on the technical parts of things. We like to focus on technical skills. We like to focus on technical components. And now we're saying, hold on, there's this whole other thing around people and how they think and how they behave and the variability that comes with that. And we have to consider that. That's really difficult to do in medicine. And then the second part of this that makes it really difficult is people are not naturally systems thinkers. We are very linear thinkers. We like to think about cause and effect. We like to think about what was the root problem that caused this particular disease state. Pick up the newspaper, if people still read them, or look at it online. You look at any major accident, and what's the conversation all about? The conversation about who is the individual to blame, or what is the single cause of that particular accident. And so when you start saying, well, hold on a minute, it may not be a single cause. It might actually be a whole host of different components that interacted to give rise to this outcome. Nobody wants to hear that, right? Nobody wants to hear that, wait a minute, there's 3 or 4 things that are interacting that might change. And we're not 100% sure that it's all those 3 or 4 things, but we think it is. And so I think overall the concept of a socio-technical system, people love it in theory, but operationalizing it is very, very difficult. And I think where the rubber meets the road is figuring out how do we actually operationalize this, and how do we get leaders inside of our healthcare facilities to really latch on to this and embrace it.
Yeah, I think just to add, it's really important that Raj talked about the impact of the rapid adoption of EHRs, and kind of why that happened. But when we talk about high reliability a lot, a high reliability organization would never introduce a technology that will have that much impact and influence on the outcomes and the production of the system without doing, super comprehensive system analysis to understand how you integrate that into the system in the best possible way. So we didn't do that well, and we're still kind of paying for that. We essentially have to have systems now that learn and continually redesign to make sure that we're giving the safest and most effective care. But we have an opportunity to do that much better with Gen AI. So we could make the same mistake as well. But if we're actually intentional and we're applying it in a way that is usable for the frontline clinicians and does affect the patients in a more positive way, then we'll get huge benefit out of that. But we just need to be careful not to make the same mistake.
Let me take us on a slightly different direction, prompted by your introduction of Gen AI into the conversation, Josh. I think in the field of how to improve healthcare systems and how we use data to help inform improvement, I sense the last 20 or 30 years has been overly focused on quantitative data. And yet now with the digital narrative that we have access to in clinical record systems, and narrative that we get from patient feedback, and narrative from complaints, and other sources of data that should also be feeding into a richer understanding of the system. What have you seen to help bring that kind of insight from narrative alongside numbers? Because really what a team needs is hard and soft intelligence, numbers and insight from stories and feedback to really understand how it's doing and whether it's improving. And I think it's tougher, isn't it, to see how you might make use of large quantities of raw narrative, either in clinicians' writings or in a patient's writings. Have you seen examples of places that are really trying to do something interesting with that and bringing that in a form that enables action? Raj, any thoughts from your work?
Yeah, I'm glad you brought that up. It's actually been a big focus of our team for almost the last decade, and part of the reason for that is I came from the defense industry, so I worked in the defense industry prior to coming to Minster Health in 2012. And when I came over, we brought several other people from different high-risk industries, where a big focus in those high-risk industries is on the concept of how do we extract information from event reports, complaints, grievance data, you name it, to really understand what's happening there. And so what our team has been focused on, and there are others that are doing this across the country, in the UK as well, have been how do we apply different computational techniques to extract trends from bodies of text, right? Whether it's patient safety event reports or clinical notes, you name it. And so our focus has really been on two things. The first is what we heard loud and clear from many of the people that are trying to understand the patterns and trends in these data is just have the computer push me trends, show me things that are happening, as opposed to making me go and look for things. And the analogy I give to this, if you're a social media user, is in most social media platforms, there's the what's trending now, right? I don't have to know anything. I can just go into the social media platform, you look at what's trending now, and it's going to give you the 3 to 5 or 7 things that are being talked about a lot, right? Like what's emerging from these different data streams. And so we mimicked that, and we took these large databases of patient safety event reports, and we essentially apply these machine learning and natural language processing algorithms to these massive databases, and those algorithms are connecting concepts, and then we push those to our users. So now we can say, in this database of 100,000 reports, here are 3 to 5 things that are sort of atypical and are actually emerging as a trend in those data. And what we found in our early testing with different healthcare facilities and patient safety organizations is people really latch on to this concept, right? It's pushing them things that now they can go and explore and verify and so forth. The second thing we did is we really simplified the entire search process. Right? So when most people are looking at these data, they tend to have some kind of hunch or hypothesis, right? Like I've seen a few different reports related to falls and wet floors, and I want to know how many reports are there like this? Is this a real issue? And so people will search. And the problem in most of our software systems that are housing all these data is the search process is very fragile. Right? It doesn't account for similar words, similar concepts. It's nothing like searching on an internet search engine that will say, did you mean? And it'll show you all these different concepts that might be related. And so we use these algorithms to make that search process more robust. And our early user testing there is also showing there's some room for improvement, but there's also tremendous benefit to enabling people to look into their data in a much more clean, seamless way. So that's been a big focus for us, and I think there's tremendous opportunity there.
Yeah, I'll add on to because Raj and I are aligned in that the event reporting data is one of the biggest, most important untapped resources for health systems. And it's not about the events themselves. It's about these things that we haven't been paying attention to because we've been too outcome biased. And so the qualitative data in those reports, and the opportunities where something didn't reach a patient to actually understand the system and potentially improve it so that other patients aren't affected is huge. And we've been talking about near misses, and the literature says 600 near misses for every adverse outcome. But we just don't have the resources to look at those 600 and be designing the system to prevent that. But with Gen AI, we will have that capability. And the same from patient feedback. It's so important to be seeking proactive patient feedback as they're navigating our complex systems. We shouldn't dive into an opportunity when something horrible's already happened and the patient's had a terrible experience. At that point, it's too late. So how do we more proactively identify where we can intervene and improve their experience? And again, we're not going to have 100 people sitting around reading those things and being able to do that, but we're approaching a period where we will be able to take action. The second thing I'll call out, Pedro and I had the pleasure of being in Amsterdam at a clinic called Expert Clinic, and they were just doing fantastic work around patient-reported experience measures and patient-reported outcome measures. It's been so frustrating that we've not been able to see broader adoption of that, despite the evidence of how important those measures are. And I do hope that Gen AI, they were using AI and machine learning to help create the necessary path for the patients based on what matters to them. So if you're familiar with the IHI What Matters to You program, they were asking the patients what matters to you, and then they're using AI to help create the necessary care pathway that's co-created with the patient. So it's really incredible work, and like the horizon is so bright for some of these things. It's been so challenging to do because of limited manpower, where Gen AI is going to actually help us achieve some of these things.
Amar, I wanna visualize this conversation 5 years from now. So Rash and Josh, welcome to the conversation. It's 2029. It's been 5 great years, and these are the things that we are celebrating for health and healthcare safety and improvement. Can you reflect on what you've seen over the last 5 years?
Over the last 5 years, we've seen the seamless integration of artificial intelligence into our care improvement process. And we now are able to, that we couldn't do 5 years ago, have all of our data in one place, single source of truth, with seamless interaction in those data to actually drive insights. And so as we think about all of the improvements that we want to make and we want to know whether they're working and how they're working, we no longer have to chase down different data sources and expend all our energy doing that like we had to do 5 years ago.
Yeah, I would say that the last 5 years we've done an incredible job at course correcting some of the mistakes that happened with the digital revolution and sort of the unintentional and chaotic way that ultimately affected our patients and clinicians by spending more time understanding those technical aspects of the socio-technical system and holding them to a standard that we've held ourselves to as clinicians for a long time. And now we're getting the most possible value out of the technology that we have at our fingertips, and we're doing that in a way that's enabling the clinicians to achieve their purpose and achieve joy in work and spend more time with the patients and less time in front of screens. And so it's taking us a little bit back in time of where now we actually can be more present and be healers and be listeners and be empathetic, which is really what technology should have done all along.
That's an alluring picture of the future that I can certainly subscribe to. That sounds fantastic. I'm skeptical as to whether we'll really get there in 5 years, because there's a lot of work to do. Just your description of the socio-technical system and really truly understanding the component parts that we need to pay attention to and influence in order to really rethink what the potential role is of technology in enabling us to understand and then improve care. It's a big undertaking, isn't it? But you both of you have really helped me think about how we might want to consider these aspects, and you shared some really great stories of places that are well underway in thinking about how to best bring technology and insights to people to help them improve care. Pedro, what are you taking away from today's conversation?
Probably the biggest takeaway from me is that we need to be cautiously excited rather than just blankly lured by the potential of technology, and prioritize a human dimension of this change, and try to integrate it into daily life as opposed to imposing it on people. And then the second thing that I would highlight is simplification, making it very, very easy for people to be able to both access and use this stuff in a way that speaks to what matters to them, which is caring, and what matters to the patients, which is being cared for. Those are two big takeaways for me, Amar. What about for you?
Yeah, I just wanted to invite Raj and Josh to maybe help our listeners think about something they could do or try. I imagine a lot of our listeners are improvers. They've come to listen to this podcast to really think about the field of improvement science and the very latest thinking in this. They may well not see themselves as really gifted, skilled engineers or technology experts. And what you're both describing needs quite a level of sophistication, I think, and partnering with different functions. And I just wonder what your advice might be to people who are intrinsically motivated and spent their careers focused on improving health and care, and have built a set of skills around systems thinking and improvement science. If the future that you're painting needs us to really think about the socio-technical system, what would be your advice to the improvers listening to this call?
Well, first off, I would caution against assuming that technology will be a silver bullet and will save us from all the problems that we have. Our greatest strength in our industry is our people. We're one of the only industries where people come to work because they want to help people. They have this deep connection and passion for that, and we have to continue to leverage that essentially. But in terms of the application, what we can do differently, your comment about the audience being improvers, I think we have to shift a little bit of what we consider the improvers, because we have for too long asked the quality leader and the quality team to kind of be the owner of improvement. But to really understand the performance of a socio-technical system and how our people are interacting with these technical tools, we need informatics, and we need analytics, and we need social scientists, and we need safety scientists. So this concept that the improvers live in this office in the basement, on the side of the campus, is crazy. We have to have a partnership of quality of operations, of informatics, analytics, and we've got to invite the safety science and the social sciences back.
Brilliant. What would your advice be, Raj?
Yeah, Josh, that's great. I'll build on that in some ways. I would push our listeners to take a single small problem. Like, there's lots of problems. There's big problems. There's small problems. Take a single small problem, either inside the facility that you work in or something at home, and try applying a socio-technical systems approach. And so what does that mean? You have to start actually get your hands dirty and think about and draw out what are the different component parts that might be contributing to this issue. And as Josh said, don't do it alone. Bring in a couple partners that are from outside of your normal sphere of influence and your circle of comfort. And so if you want to take on something like, gosh, in my computerized provider order entering interface, this medication list just doesn't make sense. That's a great one. It's actually a big problem, but treat it as a small one. And so how would you tackle that? Bring in the informaticists, bring in the frontline clinician, bring in several others, and just get your hands dirty and start trying to figure this out. Because I think until people actually try and apply this and see all the friction and challenges that come up, we're just not going to be able to make the big leaps that we want to make.
Fabulous advice. Thanks. Pedro, over to you. Sum up and close.
Yes, well, we hope that you've gotten a real strong sense from Raj and Josh that there are no shortcuts to this, that it's about learning by doing, and that there is no perfect recipe. And if we prioritize the human dimension and we then integrate the technical dimension in this socio-technical space, the magic is more likely to happen. I have to say to Raj and Josh that when I saw you in 2029, you look just like you did in 2024, which is a good thing. So you've been doing good things for yourself and for your systems and with people. And we are deeply grateful at the pragmatic nature of your comments. We hope people can use them, take them away, and do something with them. We hope to spark learning conversations through this podcast that transcend just the interaction online by watching or just listening to it, that they go away and have a conversation with their teams and just explore these ideas and expand on them. And we know that they'll be able to reach out to you if they have any questions or thoughts. So thank you for the time that you've invested here, for the work you do every day, and for the generosity of your wisdom. Amar.
Thank you so much, Raj, Josh. Huge pleasure to have you on this episode. On behalf of Pedro and me, a million thanks. Thanks to everyone for joining this episode, and we'll look forward to seeing you on the next one coming soon. Thanks, everyone.